Hello, my name is Roger Härtl. I'm a neurosurgeon here in New York. I apologize that I cannot be there in person, but I also want to thank you for giving me the opportunity to give my presentation in a pre-recorded way. So I want to talk about our collaboration with the neurosurgical team in Dar es Salaam in Tanzania. The hospital is called MOI. It's Muhimbili Orthopedic Institute. So it's a group that consists of orthopedic and neurosurgical surgeons. And we've been working together for the past 15 years or so. And I would like to share with you some of the experiences that we've had and the lessons that we have learned over the past 15 years. Thanks again for doing this and letting me talk to you. So Tanzania is a beautiful country in East Africa that some of you have probably visited. It has about 50 million people. And when we got there, I got there the first time, which was about 15 years ago, there were 3 neurosurgeons for 40 million people at the time. And they were all in one hospital in Dar es Salaam. I got there in 2008. And I met this gentleman here, Dr. Kinasha, who's still around. He was running the neurosurgical program, and back then we decided to work together. And I've been able to go back on a yearly basis. I also been to Bugando, which is a hospital further north on Lake Victoria in Mwanza, where Cornell actually has an affiliation. But we then shifted the program to MOI in Dar es Salaam because they had an organized neurosurgical program, and it turned out that that was actually really important for a successful collaboration. So that was one of the lessons that we've learned, that you really need to, as a neurosurgeon, you need to team up with a neurosurgical program. If there's no neurosurgical program, it's very difficult to really build anything. The other lesson that we learned was, especially back then, 15 years ago, surgery, there was no really big interest in surgery from any of the organized societies that do global health. Surgery was and somewhat still is the neglected stepchild of global public health. At the time, I contacted Doctors Without Borders or the Gates Foundation, and they do obviously a lot of important work, but surgery was not really on their radar. And that was a lesson also learned. The other lesson that we learned was, initially, when our collaboration started, we would bring a lot of medical equipment over, and that was something that was not really sustainable. You know, this equipment breaks down, there's nobody there to repair it, and then it's really a loss for both sides, for the ones who bring it over, but then also for the ones who end up having it there and they don't know what to do with it. Our program then, the program between Cornell Neurosurgery and the hospital in Dar es Salaam really evolved, and there were a lot of lessons obviously learned that I want to share with you. The conclusion was that in order to have a sustainable relationship between a program in the Western part, in the Western world, North America, let's say Europe, and in one of the emerging regions, and a sustainable program really is difficult to build. What we have come up with is a program that consists of 7 points. The one is the most important, obviously, is you got to go there, and we go there at least once a year, and we usually go for a week or for 10 days, and that's obviously important. We learned over the years that it was very helpful to combine that visit with a symposium. So what we started doing, we started working with the Tanzanians, and we helped them put together a conference. Initially, that was more like a local conference. Now it's really almost like an international meeting. So that takes about 2 or 3 days of the week. So we have this meeting, and then the rest of the week we operate together. That has been a very successful way of collaborating. Then as we got more funding, and the funding is really coming through patient donations, fortunately, that we have. As we got more funding, we were able to support fellowships. And those are fellowships on the one hand of Tanzanians, so Tanzanian neurosurgeons, but also nurses, ICU doctors, anesthesiologists who come to Cornell to spend 2 or 3 months observing. And then the other way around, we have funding for a global neurosurgery fellowship where a fully trained neurosurgeon from North America or Europe goes for 1 year to Tanzania. And that has been extremely important because that person is then on the ground and really helps us run this program. We focused on clinical research, and I'll talk about this a little bit more later. And then obviously every week we have a Zoom call. And the other thing that really holds the program together then are the publications. So we publish together. That gives the local Tanzanians an opportunity to really put their name out there. And that has become really a mainstay of our collaboration, these publications based on the clinical research that we do. That's the website that we have that describes the program, tanzanianeurosurgery.org, if you're interested. These are some of the fellows from Tanzania who have come to New York. The individual who we run this program with in Tanzania primarily is Dr. Shabani. He's a neurosurgeon. He's really a pediatric neurosurgeon at MOI and Muhimbili Hospital. Dr. Magogo and all the others. These are all neurosurgeons who spend time at Cornell. And then on the other hand, we also have fellows from Cornell or North America or Europe who've gone over to Tanzania. And the most recent fellow was Dr. Kadieu Magali. She's from Canada. Now she's a spine surgeon in St. Louis. The current fellow is Marta. I don't have a picture here. Our first fellow was Maria Santos, who was a pediatric neurosurgeon. She now practices in Portugal, and she was really the first full-time surgeon that we funded who went over to Tanzania for a year. So these people all had a great time doing this. These are some of the meetings that we've organized. So since 2008, we've organized yearly meetings in Tanzania. Initially, it was really something that we did primarily on our own here from New York, but now it's really the other way around. Now the Tanzanians really take the initiative to go together with our fellow who's there, and they put together a wonderful curriculum and a program, invite guest speakers from around the world, and it has been a tremendous success. This is the most recent course that we did in March of this year. In terms of research collaboration, we learned early on that it was not really feasible and really realistic to think that we were going to change clinical management there. So what we decided to do then was to document essentially what's happening rather than trying to implement protocols. We did that with head injury. So we published a lot of papers on the management of severe traumatic brain injury. Since I'm a spine surgeon, I was very interested in spine trauma, and we implemented a database or registry that has been running now for 6-7 years, where we essentially just we just follow the management of spine trauma at that hospital. There's a prospective data collection database now. We look at the demographics, outcomes, and so forth. So we started this actually in 2015. And out of this collaboration then came a lot of publications. And this has been really incredibly successful, and not only because of the research and the results, but again, also as an opportunity to get the Tanzanians involved and get their name out there, teach them how to write publications, put them out there, send them to meetings. So that's really what this collaboration is about, is not really focusing on improving specific clinical issues, but really teaching and training the individuals, collecting research data, publication, and then indirectly, hopefully having an impact on clinical management and quality of medical care. So in terms of these publications, for example, it was fascinating to see that we followed these trauma patients, and we found that there was a relationship between prolonged time to the operating room and poorer outcome. And that's, for example, that's something that's very difficult to document in North America or Europe because patients are having surgery much, much quicker. But in Tanzania, because of the long delays, we were actually able to document and then also publish on the relationship between timing and outcome. And these are just some of the cases. In terms of the implants, those implants are obviously expensive. A lot of this comes through donations from various companies from North America. Patients in Tanzania who have to have surgery essentially have to come up with the funds to purchase implants unless they are being treated under this protocol. in which case these donated implants are obviously for free. This is from one of our first publications that show the catchment area from where these patients come all to the trauma center in Dar es Salaam. You can see here these patients travel hundreds of kilometers, and it takes days for them to get to the hospital. And obviously that all leads to delays in care. These are just some of the pictures from the operating room. This is one of our residents years ago at Bugando. This was actually in Mwanza, a different hospital. And when we started going there, that obviously caused a lot of interest, as you can see here. And this is another picture from the operating room there. It was really fascinating to see that we were able to document, again, a relationship between the delays to the operating room and poorer outcome. There was also a relationship between surgery, earlier surgery improving outcome. And the reason why these patients didn't go to the operating room earlier was partially because they couldn't afford the instrumentation, or there was no instrumentation there, or they had no insurance. As you can imagine, most of these patients there do not have insurance. We looked at details of operative management. Again, this is a study that was published a little bit later then. And this study showed that each day that the patient was taken to the operating room earlier resulted in a 4% chance of increased or improvement in neurological outcome, which is quite astonishing and important, obviously. The delays in terms of going to the operating room were again related to the lack of insurance, lack of implants, and lack of funding from the patients. We were able to look at cost effectiveness of surgical treatment of spine trauma. This was a study that was really spearheaded by Scott Zuckerman, who is now at Vanderbilt, and he was there for 6 months, and he did terrific work with the Tanzanians, and they came up with this publication. So, and this was interesting to see that surgery for spinal trauma, whether it's quadriplegic or whether a patient has neurological improvement, either way, this seems to be very, very cost effective. This is a pilot study. We're working now on getting more robust data to confirm this, but it looked really promising with these first data that we gathered. When Dr. Zuckerman was there during those 6 months, they actually implemented a protocol where they tried to cut down on the delays getting these patients to the operating room. And that was a pretty ambitious protocol, but for several months, they were actually able to sustain this. And during this time period, you can see before implementation of this protocol, time to the operating room, or days from admission to surgery were 24 days, and they cut that down to 2.1 days. In patients with incomplete spinal cord injury, even to 1.8 days. And this was obviously temporary, and then at some point they had to give up this protocol, especially also because there was not always instrumentation available. This was really based on donations from companies. And these companies, by the way, have been incredibly generous. And without them, this would never have happened, of course. Now, what else are we looking at now? These were all short-term outcome data. This was all outcome at discharge from the hospital. Now, with one of our more recent fellows, we started looking at long-term outcomes. We also looked at some of the outcome data collection sheets and translated those into Swahili because they used to be in English, and that's the problem. A lot of patients there are not really comfortable with that language. So we're working on translating a lot of this into their local language, which is also a little bit of a challenge. And now more recently, we started collaborating with UCSF and the hospital MOI and the Sign Foundation. The Sign Foundation is a foundation here from North America that produces orthopedic implants and makes them available at no cost to local hospitals in Africa. And they have an interest in spine trauma now as well. And by partnering up with them, we gain access to a lot more implants, of course. And by working with UCSF, it's just a great group of people that we work with, and put this whole project on a more robust base. And we're just starting this collaboration. Another thing that we're working on is education, virtual education. During COVID, we started a remote course initially for scoliosis surgery. I was not sure that scoliosis surgery would really be so important for them, but it turns out that it is. And we had two surgeons, Dr. Ala Ahmed from Palestine and Dr. Massimo Balsano from Italy, who are deformity surgeon, who really spearheaded this program. They did online courses before a visit in Tanzania. They identified surgeons with an interest in scoliosis surgery. They did weekly conference calls. They identified patients. They prepared meticulously particular surgeries. There were companies, again, that supported this in terms of implants. And then they did a course, a 1-week scoliosis camp in Tanzania. And surprisingly, this was really one of our biggest successes because a lot of these patients that they operated on required obviously very complex surgery. And a lot of these patients would have been sent to India or Singapore for surgery, which would have been extremely expensive for the local hospital and for the government. So the fact that we were able to train surgeons then to treat these patients locally in Tanzania made a huge difference. And that was, for me, was a really interesting experience. And that's why we've been continuing the scoliosis program. And now we're going to do the third scoliosis week in early next year. In terms of leapfrogging, in terms of spine surgery, we were implementing virtual reality for teaching and training, which is something that we've been using during our courses that we do every year in Tanzania. We started using navigation for spine surgery. Initially, years ago, we started with 2D navigation, and the surgeons there really picked up on that very, very quickly. And we started, using instrumentation for trauma cases with 2D navigation. Now, BrainLab from Munich, Germany, actually donated a 3D navigation system for spine surgery that's now permanently in Tanzania that the surgeons started using there. And our fellows keeping track of this, and we're documenting the learning curve. It's very important to mention that the company that donated this equipment also committed to supporting it. I would not have done this without them really committing to a support system. And these are just some of the shots in the operating room, some of the cases that we did in March of last year. And we're collecting data on the learning curve to see how that works out in that setting. We also started less invasive or minimally invasive spine surgery using tubular retractors. Now, they only have one microscope at MOI, and that is being used primarily for brain surgery, of course. When you operate through tubes in the spine, it's nice to use a microscope unless you have these types of tubes that have a camera that is integrated, and then you can project that on a screen and operate off the screen. And that's what they're doing currently in Tanzania. Again, the company Vision supported this very generously. So they're doing minimally invasive spine surgery now off the screen. That's 2D, of course, but it's also very, very successful. And it makes a big difference because the infection rate is lower, the bleeding is less. These patients get in and out of the hospital much faster. And it helps them to retain patients in Dar es Salaam, especially wealthier patients who potentially otherwise would have gone abroad, and now they're staying there and are being treated locally. And that's also something that you have to remember. It's not only taking care of trauma and those types of situations, but also patients who have elective spine problems. If you can convince these patients to stay locally, makes a huge difference for the system there. And more recently then in March, we brought over spinal endoscopy. This is Dr. McGrath, who was part of our faculty teaching spinal endoscopy. And we got a endoscopy company now committed to donating a whole endoscopy tower that's going to come in February. And in February, we're going to do 1 week of endoscopy surgery. And I'm very excited about this because I think that spinal endoscopy may be a big hit in Tanzania. We helped the Tanzanians then over the years really come up with a educational program. We started with one course 15 years ago, and now we have an endoscopic spine course that we're going to start next year. The University of Colorado has been doing an oncology course there now for a number of years. We have the scoliosis camp that MOI is running there. Our global neurosurgery course that we started 15 years ago. Now there's a vascular neurosurgery course that's run by a team from Innsbruck and from Utah, or the endovascular course is actually run by Utah. And then the epilepsy course that Caitlin Hoffman from Cornell is running with us. So, and that has really, I think, been the greatest success. Again, initially we thought we were going to revolutionize the way that they take care of patients, but you can't really do that if you're not there all the time. But what we have done is we've helped them collect data and we've helped them put together these courses, and that has a tremendous impact also on their psychological kind of the way that they look at themselves, I guess, and that now they're teaching other programs, and this has been a tremendous success. And these are some of the research projects that we're working on together. So spinal endoscopy, navigation. A lot of this is really now leapfrogging, but again, we only do this with technology if we have the commitment from the company to support this long term. We're looking at scoliosis surgery. We're looking at spine trauma, of course, and several other projects. Again, these are our 7 points that are important for a sustainable program that I think can serve maybe as a template for other institutions as well. I want to thank you all. I want to thank the fellows that have been going back and forth now for many years. This is Anthony, who's currently a fellow here in New York, who came from Nigeria and spent a year in Tanzania. Julie Woodfield, who is a neurosurgeon in Edinburgh, who was in Tanzania for a year. Magali, she's a spine surgeon now in St. Louis. Romani is our research fellow. And then we have Marta from Paris, who is our current neurosurgery fellow in Tanzania. So thank you to all of the fellows and everybody else who's been supporting the system. Thank you so much, and hope you have a great meeting.